Okay. Okay, so we're recording. Okay, so everybody can see the PowerPoint that's up over here. This Hudson Valley Collaborative Protocol Update protocol.
Right.
Okay, perfect. Okay, so we were going to do a little cardiac and a little pharmacology, combination of the two tonight and stuff. But before I start that, does anybody have any questions on anything, you know, about what's going on as far as the COVID-19 or anything like that? I guess, you know, we've been going through it now for a couple of weeks. It seems like, you know, we're reaching the peak of the first wave. Hopefully there won't be a second or third wave, but it looks like we're, you know, reaching a peak. We countywide, from the paramedic standpoint, we've dropped down to 76 calls a day. The highest was like 140 calls a day. So, you know, we're down. The amount of DOAs and pronouncements are still pretty high. We're still averaging 5 or 6 a day, but definitely the overall calls are dropping, and the hospitals are definitely not in panic mode like they were. So that's good. I mean, you know, they're not, you know, they're not.
Question for you.
Yes.
What is the ongoing treatment modality been with NIAC and Good-Sam? I know the hydroxychloroquine is anecdotal at best at this point, and I know Dr. Raybridge really doesn't seem to be a fan of the idea based on the limited research, but what has been NIAC and Good-Sam's go-to treatment modality for their ICU? And
I don't know that, but I'll just tell you, if you want something out of the book treatment wise, you're going to have to go to a university level, you know, hospital. You're not going to be getting that at, you know, at Good Sam or NIAC or anything.
Yeah, I was just wondering what Good Sam and NIAC were doing, if they were just monitoring symptoms or if they were trying to actively treat.
No, I mean, there's a couple of things that came out today that are pretty interesting. One is that they're really now shying away from patients going on ventilators unless they absolutely 100% have to, because the fatality rate of patients put on ventilators is like 50%.
Yeah.
And they're not exactly sure why that is. There's a lot of theory and stuff, but, you know, they're not exactly sure. And the other thing is, you know, most patients that are dying from maybe say 3 ways. You know, one is that they get a sepsis, that, you know, takes over their body, so to speak. The other one is a pneumonia. And the third one is that they have their immune system overreacts to it. And that's what's happening to the younger, healthier people, is their immune system overreacts to the virus. And they have what's called a cytokine storm. So cytokine is a hormone, not even a hormone, it's a substance that's produced when there's inflammation in the body. So inflammation could be, you know, almost anything, but in this case, it's the virus. So there's, you know, some stressor on the body. And when the cytokine is released in large, it always is released when you have an infection, but when it's released in huge amounts, like what's happening in these young, healthy people, because you have to have a good immune system, right? You have to go into this with a healthy immune system. So what's happening is that it's changing the permeability of the blood vessels that are wrapped around the alveoli. So your pulmonary capillaries are wrapped around your alveoli, and that's where you have gas exchange taking place. And when it changes the permeability, they actually become more permeable. And now what happens is that plasma is able to leak out of those capillaries and flow into the alveoli, and the people drown, basically. It's called a dry land drowning. The medical term is, you may have heard, like when they give the reports, it's called ARDS, acute respiratory distress syndrome. So they thought, right, like we would think with pulmonary edema, putting somebody on CPAP, BiPAP, intubation and stuff like that would be a good way to manage them. Intubation doesn't seem to be. CPAP and BiPAP seem to have better results if the patient, you know, can just last on that. But what they're really going towards, and I think this is what Jeff is talking about, is the use of anti-inflammatory medications. So some of these medications you hear being tossed around are anti-inflammatory medications. And when they kind of calm down the immune system, people tend to do better. Now, there's always a risk of calming the immune system, which is that obviously the immune system is fighting the virus. But they're finding, you know, that it's such an over response that when they give them, and they're talking about drugs for, you know, malaria, drugs for rheumatoid arthritis, even a chemo agent, you know, so there's a lot of stuff they're experimenting with, but I don't think they've really picked any one particular thing. And I'm not sure that it will be one particular thing. I think it's going to kind of be trial and error. So, you know, that's happening. But in this county, from what I've seen, is that, you know, there's nothing cutting edge really going on. And, you know, it's hit or miss, you know, whether patients survive or not. You know, I had 2 I don't want to say friends, but two acquaintances that I know, their kids were friends with my kids in their 40s, and they both died from it. Males, healthy, and they both died from it. And then most of the other people are 70s and 80s. So, there's no way of knowing. I mean, obviously a lot of it is luck, but there's, no 100% way of knowing, who's going to get it and get a mild case, and who's going to get it and have this crazy cytokine storm and, unfortunately not do well with it. Okay, so any other questions as far as that goes? You have to conserve your PPE, right? I mean, it's really in short supply. We're not getting a lot from the county. The county's not getting a lot from the state. The state's not getting a lot from the feds. So it'll be in short supply probably, until May. And then there should be a lot of stuff coming on board. And your treatment really should be transport. If you need to give them oxygen, you would, the best way to give them oxygen is put them on a nasal cannula and then put a surgical mask over their face, over the nasal cannula too. And if you have to increase you titrate your liter flow of the nasal cannula to their pulse oximetry, and anything above 90% is considered satisfactory now. I know 94% we were usually shooting for, but anything above 90% is considered satisfactory. And if you have to go above 6 liters, you have to go above 6 liters. I mean, normally we wouldn't run a nasal cannula above 6 liters, but if you have to, you have to. The next choice would be a non-rebreather. The issue with the non-rebreather is the mask doesn't fit well in their face to help trap the surgical mask. Doesn't work well to trap the secretions and stuff like that. But if you have to use a non-rebreather, that would be okay. You want to avoid at all costs nebulizers. I mean, if you're using a nebulizer in a patient, you're putting yourself at super, super high risk because they're breathing out all of that, virus into the ambulance. And the same thing with CPAP. So both of those really should not be used, unless you're willing to, greatly increase your chances of catching it. And pretty much it's going to be transport. I mean, get them on some oxygen, get going to the hospital, minimize your time with them, make sure the vent is on in the back of the ambulance, exhausting air out, and whatever fresh air conditioning, have the air conditioning blowing fresh air in. If you still have ambulances that windows are open, definitely have the windows open, and you're trying to decrease the viral load in the back of the ambulance the best you can to, minimize your chances of, breathing it in. And the rule of a cardiac arrest now is, obviously if they have any signs of death, you wouldn't work them just like all the time. But if they're workable, there's a 20-minute window, and if within 20 minutes you don't get a pulse back in the patient, doesn't matter the rhythm they're in, doesn't matter whether they're COVID positive or not COVID positive, any cardiac arrest patient, you work and in 20 minutes you don't get a pulse back, then you just leave them, explain to the family there's nothing you could do further. You leave them, and either the medical examiner will have to come, or the funeral parlor. If a doctor will sign a death certificate, the funeral parlor will come. But we're not transporting to the emergency room for the foreseeable future cardiac arrests, who don't regain what they call ROSC, return of spontaneous circulation in the field. So, that's basically it. The medics aren't supposed to really intubate. They're supposed to use the King airway, the double lumen airways and stuff like that. And I did get today in these plexiglass boxes that you may start showing up that we're actually going to put over the patient's head and shoulders, and there's holes cut into it for the medic to stick their arms through to be able to intubate, so that it hopefully will trap the secretions, if the patient's coughing or anything like that. The problem is that they need to be assembled, when you need to use them, because they're a fold flat type of thing, and they're not super well made. We already cracked one trying to take it apart quickly, like we were trying to practice with it. But again, if they're using the King airway, it would be a much quicker procedure, and there'd be less risk of they're not putting their face close to a patient or anything like that with the King airway. Okay, so any other questions on COVID or anything like that, or anything outside of what we're really going to talk about tonight? Okay, so, and everybody could hear me okay? Everybody could see the slides and everything? Okay. Okay, so let me get it over here. Okay, so we know, one of the things that separates EMTs from people who have first aid is the ability to administer medications. And over the years, the amount of medications that EMTs can administer has grown and will continue to grow, right? As a shortage of paramedics continues, and there'll be more and more medications that EMTs will be able to use. to assist patients and stuff like that. So, with the ability to administer medications comes the responsibility to, not hurt someone, right? Because we really can, do damage to people giving the wrong medications or the wrong route or anything like that. Okay, so I'm just going to mute so we don't get any background.
Sign in and call us afterwards, okay?
Okay, so everybody's muted. If you need to talk, you can unmute yourself. Okay, so again, this is the, the kind of the rights of drug administration. So the patient has no allergies, so that's always important. That's why I put it right at the top. Now, the right person EMS-wise, that's usually pretty simple because we usually only have one patient at a time. Again, right drug. It would be pretty rare where we're giving multiple drugs. Some situations where you may, as an EMT, need to give multiple drugs. Obviously, you have a possible acute myocardial infarction, a heart attack patient, you may need to give aspirin, right? Oxygen, possibly, depending on their pulse oximetry. And then if they have a prescription for nitroglycerin, you may be assisting them with the nitroglycerin, and we'll talk about all those drugs as we go on. Again, dosing, probably the only drug you need to know the dosing with and stuff like that would be the epinephrine that you're going to use either in anaphylaxis or asthma. So we'll talk about that when we get to it. Okay. And if you're using auto injectors, is really, it's already preloaded for you. Again, the right time is the time which with the patient, so that doesn't necessarily pertain to us. That's more like in a hospital setting where they're giving medications throughout the patient's stay. Route we do need to know, okay, make sure we give it the right route, and we'll talk about that. And then the right documentation, which what should it include? So you should be painting a clear picture. Like if somebody comes back and reads your PCR 3 months from now, a year from now, there should be enough documentation in there that it clearly states why you gave the drug. So in other words, if you're giving nitro, there has to be something about chest pain in there. If you're giving albuterol, there has to be something about difficulty breathing and wheezing. So the documentation has to make it clear why you made the choice to give the medication. The other documentation would be obviously name the drug, the route, the amount, the time, and then the patient's response to the medication. Okay, did they get better? Did they get worse? If you're calling for a second round of stuff, then a repeat set of vitals usually. The only time it says you could skip vitals and actually skip patient consent would be with epinephrine in anaphylaxis. So if you had somebody who was dying of anaphylaxis and they couldn't even talk, obviously you don't need to get verbal consent to treat them. And you can actually skip the set of vitals, with somebody who's dying of anaphylaxis and go ahead and treat them. Okay. There was something else I was going to add to the documentation. I don't remember right off the top of my head now. I'm sure it'll come back to me. Okay. Okay, so an indication, right? So just some things we're going to talk about when we talk about the different medications. An indication is the reason we give it, and a contraindication would be a reason that we would not give it. Okay, now there can be precautions. So I'll give you an example, nitroglycerin, right? So we, so in you guys, they would all technically be contraindications. I'm trying to think if there's, so a precaution would be a side effect that's possible to see, but it wouldn't be a reason not to give it. Okay, so I'm just trying to think like, let's say nitroglycerin and they're on erectile dysfunction medication. So, the possible side effect is that you could lower their blood pressure, and we'll talk about that. So on an EMT level, they say, you have to have a systolic blood pressure of 120 to go ahead and administer it. In the hospital, paramedics may be blood pressure around 100. So that's the precautionary, I guess, window, where, you may still use it, okay, but you, in the back of your mind, realize that something, could be going wrong by doing it. Okay, so whoever just signed in with just your phone number, the issue is going to be is that we need to do a roster and we need to see everybody's names on the roster. So the next time, just make sure you make an account so that we could actually see your name. So it goes on the roster so you get credit. Okay, an action. Okay, just one more person just signed on. An action is what we expect the medication to do, right? So let's say albuterol. So, in asthma, they have bronchoconstriction. So an action of albuterol would be bronchodilation, okay? Side effects, so again, we could stick with, say, albuterol. So when you give somebody albuterol, the action would be bronchodilation. The side effects could be that their heart could race, they could feel jittery and uncomfortable, and that would be an expected side effect. And therapeutic level means that you get enough of the medication on board to do what it's supposed to do. So we know that, like, again, we'll stick with albuterol. The first minute of albuterol, sometimes the first 2 minutes of albuterol, nothing dramatic happens because there's not enough high enough level of the medication in their bloodstream to cause the bronchodilation. But as time goes on, right, the therapeutic level rises, okay, and then the patient starts getting some bronchodilation and feels better. Okay, so if anybody has any questions, just unmute yourself, or if I'm going too fast or anything like that. Okay, so let's talk about some cardiac emergencies. So the two, I mean, there's many, but the two main ones that we talk about on a EMT level would be angina pectoris, which translates to pain in the chest, okay, and an acute myocardial infarction, which means a sudden, okay, death of heart muscle, right? So acute means sudden, myo is muscle, cardial means heart muscle, so myocardial muscle, infarction means death of. So we would actually want to say, you know, that we treat people for acute myocardial ischemia, which means that the muscle's not dead yet, and we're trying to get them to the hospital and treat them before their muscle dies. So the etiology of both of these, okay, is the fact that we eat a lot of fatty food, okay? It could be just genetics in some people, but for the most part, the etiology is we eat a lot of fatty foods, and the inside of our coronary arteries get fat deposits, okay? And the body recognizes that those fat deposits should not be there, so it grows what's called a fibrous cap over them to kind of lock them in place. So whenever there's something in the body that doesn't belong there, the body tends to cover it. So it grows this fibrous cap over it. So picture you have the inside of an artery, right? A tube, like a hose, garden hose. And on the inside of that garden hose, there's some fat. And then over that, the body grows a cap, a fibrous cap. So we already know the issue of having the fat in there is that it's narrowing the lumen of the artery, so it's not letting as much blood through, okay? And this will play a role in a second when we talk about angina. But the cap now would seem like it's like making the situation worse, because if you have a very thick cap, you're actually narrowing the area that the blood can go through. But from a heart attack standpoint, the thicker the cap, the better off you are, because in a heart attack, and we'll talk about it more in a second, but the cap ruptures. And that's what triggers the platelets to go there. And that's what causes the heart attack. So thin caps are the ones that tend to rupture. Thick caps tend to be very stable. Okay. So let's talk about the difference. So both of them, the initial cause, right, the pathophysiology of it is coronary artery disease, right? So coronary artery disease that we're talking about would be the fat and calcium that gets into the blood vessels. So when you have angina pectoris, what happened, again, the average age of somebody with angina is probably late 60s, 70s, 80s, right? So this is a long-term disease process that took many years for the patient to get to that state. And their arteries got narrowed by the fat, but also got hardened and stiffened, okay, by the calcium that infiltrated it. And that calcium is not necessarily calcium you get from milk or anything like that. It's calcium that's just in your body that infiltrates in there, and tends to be worse with high cholesterol levels and high fat levels. Okay, so what happens in angina? Now we know that whenever we exercise, whenever we stress ourselves, whenever we run, that our coronary arteries have to dilate to get more blood to the heart, right? Because that's their role. Their role is to supply the heart with the blood it needs so it could pump, right? And then the heart itself pumps blood to all the other parts of the body to keep it nourished with oxygen and sugar and so on, and remove the waste products. But the coronary arteries that we're talking about now in angina that are stiffened and narrowed, their whole purpose, okay, is to keep the heart itself oxygenated and filled with sugar so they could beat. So now this person over the years has developed angina, their arteries are stiff and clogged, and they start walking up a flight of stairs, or they get an argument, or they shovel snow, and they increase what's called their myocardial oxygen demand. So myocardial oxygen demand means how much oxygen the heart needs at any given time. So us sitting here, okay, we need very little. But that person shoveling the snow, walking up a flight of stairs, you know, running for the bus, they've suddenly increased the amount of oxygen their heart needs. And because they have this condition where their arteries in their heart are narrowed and stiffened, they can't get that extra oxygen to their heart now to keep the muscle perfused. So the heart muscle switches from what's called aerobic metabolism, which is making energy with oxygen, which is the way we do it 90% of the time, to what's called anaerobic metabolism, which is making energy without oxygen, or without a lot of oxygen. So when you have aerobic metabolism, you make a lot of energy. And from, you know, those who remember your sciences, from the standpoint of energy, we call it adenosine triphosphate, right? That's the energy molecule. So you make a lot of ATP, and the waste product is carbon dioxide and water. So it's a great thing when you do it with oxygen and sugar. You make a lot of energy. It's good energy. The heart can pump very well. And the waste product is very easy to get rid of. So carbon dioxide we exhale, and water we either reuse or excrete. So that's perfect energy. That's the way you need to do it. And that's called perfusion, when you're feeding the cells with everything they need to, stay alive. Now, when you don't have enough oxygen, it reverts to anaerobic metabolism. So there's an AN in front of it, anaerobic metabolism. And that means that you're making energy without enough oxygen. And the problem with anaerobic metabolism is, one, you still make a little bit of energy, but not enough. And two, that the waste product is something called lactic acid. And we've all felt, lactic acid in our muscles. It gives us that burning sensation, that painful sensation. And that's the exact thing that's causing their chest pain. So, the exact cause of chest pain is lactic acid. The reason they have lactic acid is lack of oxygen. So usually on a test, the answer is lack of oxygen causes chest pain, but the lack of oxygen is what causes them to revert to anaerobic metabolism, which makes the lactic acid that causes the chest pain. And if you ever gone upstairs when they do angioplasty, right? So, patient's usually uncomfortable, is usually in pain, cold. And then they put them upstairs, they catheterize them, they bring the balloon up to the narrowed artery. And when they inflate the balloon, the pain increases dramatically because they've completely blocked off the artery while it's inflated. And then they decrease it. Right now they've opened up the artery a little bit, so the patient feels a tiny little better. Then they have to inflate it again, maybe 2 times, 3 times to get it completely open. So every time they inflate it, they're in excruciating pain because no blood's getting through that artery that's, partially blocked before. And now when they did the balloon, it's completely blocked. But then once they pull the catheter out of the heart, pull the balloon out of the coronary artery, and leave the stent in there, you see right away that the patient's pain level, is actually back down to normal, and they start to dry up and pink up and everything like that. Because what did they do? They reperfused that area of the heart that was denied oxygen. So they took it from an ischemic state, okay, and brought it back to a, hopefully a normal state. The patients that wait too long, okay, or patients that, go to hospitals that can't do this, then if that tissue stays ischemic without oxygen for a long period of time, it moves to the infarction stage where it dies. And that's it. Then that doesn't mean the patient dies, but it means that section of the heart muscle died. And if enough, we all know, if enough section of the heart muscle dies, the patient doesn't usually live, especially if it's the left side of the heart, right? Especially if it's the left ventricle, because that's what pumps to the, the whole body. So angina is a temporary situation that's brought on by an increase in the amount of oxygen the heart needs by running or whatever. And the patient gets this sudden onset of retrosternal chest pain, right? Hits them right in the center of the chest, usually, typical chest pain. They hopefully sit down and stop what they're doing, because somebody could, somebody having an angina attack could, if they continue to do it, actually cause an infarct, not by a typical way, which is a thrombotic event. We'll talk about in a second, not a typical heart attack. Just by increasing the myocardial oxygen demand to a point where the muscle actually starts to, get seriously injured. Now, most people do not do that, okay? But you always, I can remember a couple times going to somebody shoveling the snow and, wanted to get it done, and tried to continue doing it right through the chest pain and stuff like that, and, suffered more injury than they should have. But typically what happens when they have the onset of chest pain is they sit down, okay? And, within a couple of minutes of sitting down, the pain should actually start to decrease because they've reversed what they call the precipitating factors. So if shoveling snow was the precipitating factor and you stop doing it, already your heart needs less oxygen. Okay, now sometimes it doesn't help a whole lot because they're scared and saying, oh my God, I must be having a heart attack. And that causes adrenaline to be released. And, they're scared because of that, and that increases their myocardial oxygen demand. And then, the police officers come, put them on oxygen. We come, make them comfortable, continue on the oxygen. Now, if it's the first time they had angina, nobody knows they have the condition, right? So they don't have nitroglycerin. But if it's the second, third, fourth time and they were given nitroglycerin, EMTs in New York State are allowed to assist a patient, with taking nitroglycerin, and we'll go through all those medications in a second. Medication, nitroglycerin is what they call a vasodilator, a smooth muscle relaxant. So it's going to dilate the coronary arteries, okay, and get some extra blood through there. And, we have an interesting thing in our body. So, we said that this coronary artery disease that causes angina and a heart attack is a very slow process, takes years, decades and decades to develop, okay? In saying that, they have done autopsies on these young soldiers that have died, in Iraq, Afghanistan, and stuff like that. And they found that actually a lot of them do have early coronary artery disease, and that's, again, because of our bad diet that we have. So it does start early, okay, and it is somewhat reversible, right, by stopping to eat that food. And if you really have a high lipid level, high cholesterol levels and stuff, getting on anti-cholesterol medications if you can't control your cholesterol with diet and exercise and stuff like that. But going back to the situation with the nitroglycerin and the vasodilation. So I said it's a slow process that happened over a long period of time. So the body doesn't say, Frank, you didn't take care of yourself and that artery's done and, you're going to be in big trouble. What it does is it actually grows what's called collateral circulation. So it senses that an area of the heart is not getting enough blood. And, all the time it's not getting enough blood because that artery is narrowed, and it actually grows more blood vessels. That collateral circulation doesn't usually occur to people until there are people in their like 60s. And you've all heard of these young people have a heart attack and die, right? Or have a bad, they're in their 40s, have a heart attack and have a horrible outcome. And you've also heard about this 70-year-old who says, oh, my doctor told me I had 6 heart attacks, and they're walking and talking. The reason why is they've developed collateral circulation. So even when they blocked off a blood vessel, they had enough blood vessels in the area that area of the heart still got some blood. And they didn't have as big an infarct as the young guy who doesn't have collateral circulation. So that's, one of the problems with having a heart attack young is that you don't usually tend to do as well unless you recognize it right away and get to the hospital and get that artery, ballooned open with angioplasty. So, it's definitely, so that's what nitroglycerin does is it vasodilates and opens up those blood vessels. It doesn't do a good job in opening up the narrowed, clogged, calcified one, but it definitely opens up the collaterals and you get more blood to that area and stuff. So the combination of reversing the precipitating factors, getting some oxygen, calming down a little bit, getting nitroglycerin, usually will reverse the attack, reverse the angina attack. Now, that's garden variety angina. There are different types of angina. There's Prinzmetal angina, which is a spasming of the artery. Nitro can work on it, but doesn't usually work as quick. And that could happen to someone without any exertion. So that's just a condition where their artery spasms. So you're going to say to them, well, what were you doing when it happened? They're going to be saying, I was sitting here. I wasn't stressed. I wasn't watching football. I wasn't arguing with my spouse. It just hit me. So that's more like a Prinzmetal angina type of thing. And remember, chest pain can be caused by something besides a heart attack, right? You could have somebody having a pulmonary embolism, somebody having a thoracic aortic aneurysm. So there's a lot of different reasons why people can have chest pain. And that's part of our, differential diagnosis when we treat these patients. Unstable angina, you may hear people saying, that's where the pain starts happening with less exertion. So they usually, to get the definition of unstable angina, they usually have to have angina, right? And they've had angina for years. And usually they'll say, I have to walk 2 miles before I get chest pain, or I have to walk up 3 flights of stairs before I get chest pain. Now they're going to say to you, it takes 1 flight of stairs and I start developing chest pain. So unstable angina just tells you that the disease process is progressing and they're considered to be at higher risk for, for a heart attack. Okay, so before I go on to the heart attack, the acute myocardial infarction, are any questions on angina? And we're going to review all the medications in a second. So, but as far as the etiology of it and what happens and all that stuff, anybody have any questions?
So Frank,
yes.
So Frank, I know you're going to go on to AMI, but from our point of view, if somebody this is their first occasion they've had angina, would we, for example, cause any harm by giving aspirin?
Great question.
Effectively treating it as if it were an EMI.
Yep, good question. So I would say is if it's angina, and how you're going to tell the difference from angina is that the pain should be going away, right? In a heart attack, the pain is not going to go away until they have the stent put in. But in angina, right, after you the cops get them on oxygen, you calm them down, and stuff like that, and the pain starts to get less, there's probably not a need for aspirin. But what I would say is if you're not sure, I would call medical control and say, we have a X amount of, 55-year-old gentleman, sudden onset chest pain while mowing the lawn. Okay, the pain was a 9 out of 10 at its worst. And since he's been on oxygen and at rest, the pain's a 5 out of 10 and seems like it's getting better. Do you still want us to give aspirin, or would you want us to withhold the aspirin? The one thing you have to ask the patient before you call medical control is, do they have any allergies to aspirin, right? So if they have a history of aspirin allergy, then you would not be thinking about aspirin. So, that would not be a choice to be able to give them. And we'll talk about aspirin in a second, as far as that stuff. But that'd be the one time you absolutely cannot give a patient aspirin is if they have a history of anaphylaxis to aspirin, because obviously, you know, if somebody's truly having a heart attack or even angina, and you give them aspirin and cause an anaphylactic reaction, their outcome is going to be horrible. And if you treat the anaphylaxis with epinephrine in the midst of a heart attack, right, it's just, it would be something you would not ever want to have to say that, you know, you had to do or anything like that. So, you know, if you're not sure, you can't get medical control, patient has no history of allergies to aspirin, and, you know, you're not 100% sure it's angina, you could give them aspirin. It's not going to hurt them in that situation. It's not going to help them, because there's not the problem that aspirin works on in angina, and we'll talk about that in a second, but it would not hurt them. Okay. Any other questions? Okay. So it looks like we're up to 8 people now. Okay, so the acute myocardial infarction patient, right? So we said same etiology, coronary artery disease. Okay, most, like 90% of it is the same etiology. Okay. So what happens the vast majority of the time is you have that same fat, you have that same fibrous cap that grows over it. And in acute myocardial infarction, the fibrous cap ruptures. And the number one cause of rupture is the same thing we were talking about with the COVID patient, is the high levels of these inflammatory substances that are released. Okay. Now, they can be released from stress. They can be released from colds and viruses. They're actually very high. All of those levels of those stress hormones are very high when you first wake up in the morning, which is why most heart attacks happen when you first wake up. But there's no real exertional issue with a heart attack, okay, unless they're having angina, okay, and they you know, keep on doing it once the pain hits. Most of the times, the typical heart attack is not exertional. Now, you can make an argument that if somebody exerts themselves, their blood pressure is higher. And if their blood pressure is higher and it's the blood going through those arteries is higher, that it could cause that cap to rupture, which is a possibility. But most of the times, okay, most heart attacks that we've gone on, I'd feel confident to say 75, 80% of heart attacks, people tell us, you know, it happened without exertion. It happened at, I don't want to say sleeping, but it happened, you know, usually in a sitting, restful position. Again, the only reason it's more common in the morning is that those levels of those inflammatory substances in our body are high in the morning. It's a primitive function to raise your stress hormones in the morning so that you're prepared to go out. You know, if you were like the caveman kind of person back in the day, going out into a hostile environment, you know, leaving your shelter and going out to a hostile environment, you'd want to kind of be hyped up and, you know, ready to defend yourself. So that's why they believe they're high and stuff. So now what happens is the cap ruptures, okay? The body thinks there's a cut. And you know already that when there's a wound or a wound in the body, it sends platelets. The problem here is those platelets start to clump, okay, and stick to that ruptured plaque, okay, you know, inside the artery. And very quickly, over a period of, you know, 30 minutes or so, they start to completely close off that artery. So aspirin, why aspirin is so beneficial is aspirin interferes with the ability for the platelets to stick together. It's called platelet aggregation. So the quicker somebody takes aspirin or is given aspirin, the less clotting or less blocking of that artery occurs. So if you had a sudden onset of chest pain and chewed 4 81 milligram chewable baby aspirin and then swallowed them, you'd probably have very little platelet clumping to the area of the injury. You know, the problem is that most people right away don't assume they have a heart attack, nor did they have baby aspirin. And, you know, they call for the ambulance and maybe they waited a little bit and the ambulance took a little while to get there. And you're talking now 15, 20, 30 minutes from the onset of their chest pain before they start getting aspirin. And by all means, the aspirin given is still important, but whatever clumping occurred because you're not breaking apart that clump with aspirin. You're stopping further sticking together of platelets, but you're not undoing the ones that are already stuck together. That requires drugs called thrombolytics. And you might have heard years ago, like TPA was a drug we used, you know, before there was angioplasty. So the only time people get TPA now is if they can't get angioplasty because the hospital they were taken to doesn't have it, or, you know, the cath lab was already occupied with a patient undergoing a procedure, so they can't have 2 people there at the same time, you know. But thrombolytics would break down blood clots and stuff like that. Okay, so that's the etiology of the heart attack the vast majority of times. Now, what else can you have? You can have an aneurysm, which is that the artery gets a weakened area in it, okay, and it bursts. That patient will be dead pretty quickly, matter of minutes. What will happen is that blood will flow into the pericardial sac that's wrapped around the heart, and it will fill the sac and crush the heart, and that's called pericardial tamponade. So if it's a tiny little leak, they could present with chest pain, look pretty crappy. And, hopefully if they get to the hospital and get a ultrasound, they can see that going on inside their sac. It's kind of something like you might have heard pericarditis is a similar thing, more from an infectious standpoint, a pericardial effusion. But a ruptured, aneurysm of a coronary artery is usually a fatal event. But if it's recognized it's not terrible, they can do what's called a pericardiocentesis, and they stick a long needle through their chest wall, right from the outside into the sac, and they can again pinpoint with ultrasound where the sac is, and they draw the blood out. And buy them time, and I guess they would have to have then bypass surgery to repair that aneurysm. There's other things. There's that spasming type of situation, but the most common is the thrombotic event. So there's a test question, because I didn't mention, but we're going to take a test, or you guys are going to take a test after this is over. I'll email it a link to a website, and you're going to log on and take a test. You have to get a 70 or better, because that's the grade on the state exam, and you get 2 attempts. If you need an additional attempt, let me know, but nobody's needed an additional attempt yet on any of the exams. And as soon as what'll happen is when you pass, you'll get emailed a certificate saying, congratulations, you just completed this, and here's your CME certificate, and just hold on to that. And eventually when we're able to meet in person again, I'll get them from you. I actually get them by email, so I'll put them in your file. So actually I don't even need them, but that's how you'll get proof of being here tonight. Okay, so again, just remember the acute myocardial infarction is more thrombotic, right? Embolic is more like strokes, pulmonary embolisms, and embolism is that thrombus, that clot that developed in the artery, a piece breaks loose and flows somewhere else. So like if it flows to the brain, you have a stroke. If it flows to the lungs, you get a pulmonary embolism. Now, most of the times when you have a stroke and a pulmonary embolism, the clot does not come from the heart, obviously. The most common cause of a pulmonary embolism is what they call a DVT, a deep vein thrombosis in the leg, caused by people not moving around enough, and it breaks loose, comes up the right side, right up the inferior vena cava into the right side of the heart, and pumps through the right atrium, through the tricuspid valve into the right ventricle, and then goes out into the pulmonary artery and lodges in the pulmonary artery. And that's what a pulmonary embolism is. And it's a very, very serious condition. But again, that's embolic. That's a piece that floated from somewhere else and got lodged. Where a heart attack is thrombotic, it happens, the clot develops at the site because of a rupture of the fibrous cap. And the same thing, probably the most common cause of a stroke is that a patient has AFib. Okay, and it can be diagnosed, undiagnosed. And when you have AFib, the atriums do not contract fully, right? They don't contract well. They're fibrillating. And when something doesn't contract fully, there's always a chance for blood to clot in there. And then all of a sudden, they have a time where the atriums do contract well and it showers out clots. And if the clot comes from the left atrium, it goes to the left ventricle. And then from the left ventricle, it goes out into the aorta. And when the aorta comes off the left ventricle, it goes up in arches before it drops back down. And off the arch are what they call the 3 sisters, the 3 blood vessels. And, one of them goes up to your brain, and the clot goes right up into there. So that's a, common cause of a stroke. Again, people have strokes from aneurysms too, but those are not the ones that, we have great success in treating. So that's why you always have to get a CAT scan to tell them whether it's a dry stroke or a wet stroke. If it's a dry stroke, they try to give them medication to break down the clot, and sometimes they even go and try to pull the clot out at like a Westchester or a Hackensack type of hospital. But if it's a wet stroke where they're bleeding, then usually there's not a whole lot to be done unless a neurosurgeon decides to go in and try to see if there's something to be done. But usually aneurysm types of strokes have a horrible outcome. Okay, so any questions before we move on and start talking about the specific medications or anything like that? No questions? Okay, so assessment wise, you know all the typical questions that you would ask. Remember your OPQRST. So onset, right? What were you doing when it happened? Provocation, does anything make it better or worse? Yeah, better or worse. Okay, quality, can you describe to me how it feels? So don't ask them, is it a sharp pain? Is it a dull pain? Because whatever you say, they're going to say yes to. So you ask them to describe it. Okay, radiation, does it go anywhere? Okay. Most people having cardiac chest pain usually hits them dead center in the chest. It may radiate to their jaw, their shoulder. Years ago, we used to talk a lot about the arms, but that doesn't seem to be the most common thing. It's more jaw, shoulder, back, and stuff like that. Severity on a scale of 1 to 10, with 10 being the worst. You know, what was the worst number? What is it now? Anytime you do something for them, you ask them if it changes. And time is, you know, how long has it been going on? Some people who are having heart attacks and it damages their left ventricle go into pulmonary edema, so they may have some shortness of breath. Orthopnea is shortness of breath by position, which means when they're flat or close to flat, they have more shortness of breath than when they're sitting up. Diaphoresis is a cold sweat. Remember, it's never normal to have a cold sweat unless your sympathetic nervous system is activated and adrenaline is released. So the reason this happens in a heart attack patient is they're scared. And whenever you're scared, adrenaline is released. Whoops. The anxiety, restlessness, again, is the scaredness that's causing the epinephrine to be secreted. Feeling of impending doom. So I'm sure if you've been doing this long enough, you had somebody, right, who said to you, you know, Frank, I don't think I can stay awake anymore. I feel like I'm, you know, going to die. And sometimes they do, right? So there are some people who have that sensation that, you know, this is it. I always kind of tell them, you know, don't close your eyes, keep on talking to me, you know, because if you close your eyes, it's not going to be good. Fight it, you know, stay awake and stuff like that. Sometimes it works, sometimes it doesn't. If they do go into cardiac arrest, that is a time to punch them in the center of their chest. Even though we don't talk about it a lot, but, you know, give them a good, strong precordial thump. And sometimes they're going to open their eyes and say, why'd you do that? You know, and that little bit of pounding in the center of the chest causes a little bit of electricity to be released. Okay. And, you know, sometimes it actually stops them from going into VFib or converts to VFib. There is a thing called cough CPR too. If you have a patient who looks like they're going out of it, you can encourage them to cough. Sometimes that helps. Okay. And if you really had a heart attack patient you're going to is still alive and they just look like they're not going to make it, I would put the AED pads on them before you need it. Okay. Just in case they code, so you don't have to, you know, all of a sudden start trying to strip them and everything. And if you're going to put it on early, put one anterior, right in between their nipples, and then one posterior directly behind them. That first one. That is the best way to defibrillate everyone. We don't usually do that when somebody's supine, dead, unconscious, because it's hard to roll the person, hold them on their side. But anterior posterior is the best way to defibrillate somebody because the flow of the electricity is straight through their heart, where the typical way where we do one up, you know, by the right clavicle, and the other one on the left side of their thorax. That's okay. We do it all the time, but the better way would be anterior posterior. The way you were taught to put the pads on a pediatric patient would be the better way for everyone. And the AED will still analyze. There'll be no issues or anything like that. That'll be the better way to do it. You may get a question, you know, by like if the paramedics come or the get to the hospital and they're going to say, where's the second pad, right? You know, but the AED wouldn't work unless you had both pads on. So people should recognize right away that there has to be a second pad on. And if they don't see it, that it's on the patient's back. The nausea or vomiting is the very classic of the inferior wall heart attack. So patients having the bottom wall of the heart that sits above their diaphragm and their belly, when they have the heart attack down there, they get the GI symptoms, right? You always heard sometimes heart attack patients can have more gastrointestinal. That tends to be a little more common in women, but definitely can happen. Fatigue is the #1 complaint in older patients because they tend to have nerve ending damage as they get older in their 80s and 90s, so they don't feel the pain the same way. So fatigue, lack of, you know, activity and stuff, and palpitations if they, you know, if they're in a fast rhythm. So those would be all typical things you could see in a heart attack patient. Okay, so what do we do? So position of comfort, right? The more comfortable they are, the less adrenaline they'll be secreted. The less adrenaline, the less taxing of the heart. Put them on some oxygen, okay? So if they're satting, you know, 94% or higher, okay, then they could go on a nasal cannula at 2 liters. If they need more oxygen, you can put them on more oxygen, but you really want to be, you know, 94, 95%. If you truly believe it's a heart attack and they have no contraindication to aspirin, then they can get 4 81 milligram aspirin. So now we know that we have to tell them, well, first of all, you know that it has to be non-enterically coated aspirin, which means that there's no hard coating on it, and they have to chew it and swallow it. Okay, so you have to be very specific to tell them, you know, please chew it, grind it all up before you swallow it. It'll go to work much quicker. If for some reason they just swallow them, then give them another 4 and tell them to chew it and swallow it. If they took aspirin before you got there and they did not chew it and swallow it, you can go ahead and give them 4 more, but tell them to chew and swallow it. It's all in the new protocol now. And don't fear that 324 milligrams or 300, it comes to about 325 if you do because it's 81 point something. That 325 is half the dose. People used to take 650 milligrams when they had a headache, when we used aspirin for headaches and toothaches and all that kind of stuff. So you're not giving them a high dose. Okay, so you don't have to fear if they take a second one. But if they took it appropriately, then you don't need to give them the second, second dose and stuff like that. Again, who would not get aspirin would be the patient who has anaphylaxis. Okay. There's a theoretical concern with asthma patients and aspirin that it may cause an asthma attack. But again, if they're in the midst of a heart attack, the benefit outweighs the risk. Okay. There's also, people talk about GI bleeds and all that stuff. So if they're really unlucky and they're having an active GI bleed and a heart attack at the same time, I would call medical control and say, what do you want to do? So, I mean, they're telling you, I got blood pouring out of my butt. Then I would call medical control. If they tell you in the past they had GI bleeds on aspirin and they're not currently having one, you could explain to them that you're giving them 4 baby aspirin and it's not going to cause them to bleed again. But if they are truly having a heart attack, that it's be very important for them and it could save their lives. And if they refuse, you just document that the patient refused the aspirin. Okay, they're still going to get it in the hospital. They're not even going to ask them, but you just document that you offered it to them and they refused it. I think those are basically would be the contraindications to using it. Okay. Then as far as nitroglycerin goes, okay, if the patient has a systolic blood pressure greater than 120, they obviously have their own nitroglycerin. They have a prescription for it by their doctor. Okay, they haven't taken any erectile dysfunction medications. Now, on a BLS level, they go out to 72 hours. Really, in all honesty, 12 hours is probably all you really need, unless it's one of the extended release versions. Like I think Cialis has the one where they tell you you take it on Friday and it's good for the whole weekend. That one you probably want to wait 48 hours. But and the reason why is that ED medications can cause vasodilation. That's how a man gets an erection, is by vasodilation in the penis. So since they can cause vasodilation, and since nitro causes vasodilation, when you have 2 medications that do the same thing, they potentiate the effect and they do it too well. So if you cause somebody to, precipitously drop their blood pressure real low in the midst of a heart attack, then obviously the heart's getting less oxygenated blood and they'll have a bigger heart attack. So that's the fear of it. If you listen to the state protocol update, they told you not to worry about that anymore. So I actually sent them a letter telling them they were wrong, and they then corrected it. So they put out a letter saying, that please disregard that we said that, and you should still withhold it and stuff like that. I don't know where it came up from. It very rarely happens, but if you read the medication inserts that come with Viagra, Cialis, and Levitra, it specifically says not to take it in conjunction with nitrates. So I don't know which rocket scientists at the state decided to put that in the protocol update, but they did put out a letter saying that that's that is to still be followed. Now, you would think in that situation, and you'd only have to worry about asking men, right, about ED medications, because only men should be taking it. But the active ingredient in these medications is something called sildenafil, and sildenafil is being used to treat other conditions, BPH in men, where the prostate gets enlarged. It's also being used for. So if someone tells you they have an enlarged prostate, they could be on this, and you'd have to also use precautions if they're taking. Now, when they use it for, so the term Viagra, Cialis, Levitra, that's a marketing term, that's a trademark name that's on ED medications. But the sildenafil is a generic name. So you'd have to look more, on the generic side to see what the medication is. And the other one, which women could be using besides men, is pulmonary hypertension. So pulmonary hypertension is they have high blood pressure from the right side of the heart to their lungs. So into the pulmonary vessels that go from the right side of the heart into the lungs. And the number one cause of pulmonary hypertension is COPD, is smokers. So you could have a woman who's a COPD and she has pulmonary hypertension. She'd be put on these medications for its vasodilatory effects. And again, she should not get nitrates. So that would be the ones that should not be getting it, okay? And again, we said that the blood pressure should be above 120. Technically, we're supposed to assist the patient, but assist means up to and including you giving it to them if you have to. You can give up to 3 doses of nitroglycerin 5 minutes apart. If the chest pain's not relieved with the first one, you can give a second one, a third one. Just check the blood pressure in between. Remember, it's a sublingual medication, which means it goes under the tongue. And how we know that it's working and it's still potent is that the patient will feel a tingling under the tongue. And remember, it could become as a tablet or a spray. Tingling under the tongue, okay, and also they get a mild headache from it. So if they don't feel tingling and they don't get a headache, there's a good chance that the nitroglycerin is not potent. That's much more of an issue with the tablets. the little white tablets than it is with the spray. The spray tends to last very long, but the spray, each one of those spray bottles is $500. And so if you don't have great insurance, okay, you probably get the tablets, okay, and the tablets don't last very long. Okay, so he said 3 doses, 5 minutes apart, okay, and again, the blood pressure has to be over 120. We talked about rechecking blood pressures, okay, and then obviously that patient needs to go to an angioplasty center. And that's, you can transfer 60 minutes out of your way to go to an angioplasty center. Now, it's not an issue in Rockland County because we have Good Sam and soon we'll have NIAC, so both of them will be doing it, so we'll have more than we need. But if for some reason, you know, neither one was available, it would be fine to go to Westchester, it'd be fine to go to Hackensack, it'd be fine to go to Valley, you know, or any of those hospitals, Englewood, because again, they recognize that the most important procedure would be the aspirin's the most important, but secondary would be the angioplasty on those patients. So you can go 60 minutes out of your way if you had to.
Frank,
Okay, so, yes.
quick question. For women with pulmonary hypertension, what's the trade name for Cetaphil?
I think it's something with an R, Revidio. Let me see. Just bringing up my browser. Revatio. Revatio. Revatio.
Thank you.
Okay. There's actually, when I was searching, there's actually a medication, I guess, that just came to market now for it, but it's not a sildenafil type of medication, so we don't have to worry about the nitrates to it. I guess it works a different way. Okay, so again, on the test, we said aspirin interferes with platelet aggregation or clumping where it sticks together. Okay, and the only contraindications would be anaphylaxis to aspirin, right? So again, if they're having an active GI bleed, which I've never had in 30-something years, somebody having a heart attack and active GI bleed, call medical control and ask them what they want you to do. Okay. Now this is showing you what the platelet clumping is. This slide over here. So basically, this was can you see my cursor moving on the slide? Can you see my cursor moving on the slide?
Yeah.
Okay, so this would be the fat, right? And this is where this red stuff is where it ruptured, and that's the platelets, okay, kind of going to it and sticking to it. And they're going to continue and they're going to clog up the entire artery. So that's what the platelets sticking to it would kind of look like, okay? Again, aspirin is oral. They're going to chew it and then swallow it, and 4 to 81 milligram aspirin. Nitroglycerine, we said, is a smooth muscle relaxant. Okay, and it actually relaxes all smooth muscle in your body. So if somebody was having an asthma attack and a heart attack and you give them nitro, it actually not only relax their coronary arteries, but it will relax their bronchioles. If they were having a spasming of their esophagus, it will relax that. So it's an interesting drug. It acts on a lot of different smooth muscle. Okay, but anyway, we're giving it in this case, obviously, for its blood vessel relaxation. Okay, so the patient's going to have a prescription for it. They've had a history of angina and they were given it, so we don't carry it as EMTs or anything like that. And contraindications, I never heard anybody being allergic to nitroglycerin. They can tell you that they don't like the way it makes them feel or something like that. It gives them a headache, but you know, it's, again, you have to have informed consent. So you could say to them, listen, you know, the doctor gave it to you for a reason. If you don't want to take it, we can't force you to take it, but we would recommend. And if they don't want to, you would tell them, you know, no, you know, then fine, we won't give it to you, but you know, we're just going to document that stuff. The same thing like the aspirin. You'll get patients who will argue with you about giving them aspirin because they were taking aspirin for arthritic pain years ago, right? So they had arthritic pain, doctor put them on aspirin, and it caused them to have a little bit of GI bleeding. And the doctor told them, okay, no more aspirin for you. and they remember that, right? And now you tell them you're going to give them aspirin because you think they're having a heart attack, and they say, no, 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 I'm allergic to it. Doctor said I can't have it. So you have to kind of tunnel in and say, well, what exactly happened? Did your lips swell? Did you have trouble breathing? And they're going to say, no, I had some bleeding. And that's not an allergic reaction. That is a normal reaction because aspirin interferes with, clotting. So you could explain to them that the benefit of aspirin in what we think is wrong with you, to give you 4 baby aspirin outweighs the risk of bleeding. There's a very small chance that you will ever start bleeding again, okay, from these 4 baby aspirin that we're giving you now. But if you are having a heart attack, it's going to definitely improve your outcome. I wouldn't say definitely, but it can improve your outcome. So we'd like to give it to you. If they refuse, again, just document that they refuse the aspirin. Okay, again, contraindications to nitro. I don't know anybody who's had an allergy, blood pressure below 120 on a BLS level, the suspected inferior wall MI. So we as paramedics would not give nitroglycerin to an inferior wall MI. So you should not give it. Now, the problem is you have no way of knowing it. So if the patient has more GI symptoms, right? They have belching, they have indigestion, they say it's my stomach, okay, but you're thinking it's more of a heart attack, I would stay away from the nitro because inferior wall MIs, again, have more of the GI symptoms than they do the chest pain type of thing. So I would stay away from it. Nitroglycerin doesn't work well in inferior wall MIs. It really makes them sicker, or drops their blood pressure and stuff like that. So you don't really want to give them nitro. Okay, so again, we said you can't use it if there's ED medications, right, on board within the last, the last couple of days. The last couple of hours. Again, 72 hours for BLS. We said that it's being used to treat BPH, okay? It's also being used to treat pulmonary hypertension. And people who have BPH may be put on a different class of medications that are called alpha blockers. This Flomax right here is the #1 medication used to treat BPH. Alpha blockers can drop blood pressure on their own. So again, you wouldn't want to give somebody who's on an alpha blocker nitro. So that would be just, another thing we don't really do. But, so if they tell you have BPH, probably trying to kind of stay away from nitrates with them. Okay, again, you can give up to 3 doses 5 minutes apart as long as their blood pressure stays above 120. It's sublingual under the tongue. If the patient's having a hard time sticking their tongue up and curling it so you can get underneath that, the best way to lift their tongue up is to grab it with a 4x4. Have your gloves on, but you can't really grab a tongue well with gloves. So just use a 4x4, your gloved hand, 4x4, grab the tongue, lift it up, put it under there or spray it under there. Okay, so any questions on the cardiac stuff? Any questions on angina? Any questions on a heart attack? Any questions on nitro, aspirin, oxygen, anything like that? Everybody's good with that? Okay. We will, this is being taped. So what I will do is I'll send you a link to the YouTube channel that'll be hosted on, and you can review it again if you want to or anything like that. I emailed out the PowerPoint handouts. The PowerPoint handout will also be on the YouTube channel if you want it for any reason. Okay, so let's do asthma, and then we'll call it a night. Okay, so what is asthma? Asthma is what they call an episodic disease. Okay, so episodic means that it comes and goes. It has episodes. So asthmatics can be fine, and then they are exposed to what they call a trigger, which is something that causes them to have bronchospasm. Okay, and then they have trouble breathing because their bronchioles get narrowed. Okay, so like I said, most of the times they're okay. They're usually taking maintenance medications to stop them from having that reaction. And then they also have what's called rescue medications. They're a rescue inhaler. So they have their maintenance ones, maybe oral medications, maybe inhalers, but those are designed to not stop them, to prevent them from having an asthma attack. Their rescue inhaler is the only thing that's going to help them if they are having an asthma attack. And 99.9, of rescue inhalers are albuterol. Okay, they may have a second medication mixed in with it, but their main medication is albuterol. Okay. Okay, so again, it's a reversible smooth muscle spasm. Most of the times it's reversible. It's not reversible, they die. Okay, but most of the times it's reversible. Okay, associated with, it's called hypersensitive airway disease, where they have a trigger that causes them to have that asthma attack. And there's many different triggers. It could be seasonal with the pollen or smoke or something like that. Exercise, stress, a lot of different triggers out there. So the smooth muscles that line the bronchioles contract, they swell, they get edema in them, they swell, and then the real fatal thing is that they get what's called mucus plugging. Mucus plugging means that we know we have mucus, right, that lines from our nose all the way down to our bottom bronchioles, right below our alveoli, And that mucus is kind of a trap for all the stuff that should not be in your lungs. So you produce mucus and it moves its way up towards your nose, and you basically swallow most of your mucus that you don't need. So as it gets back up to your throat, you swallow it and digest it. Some of it you obviously sneeze out or something, gets out of different ways, but most of it you swallow. Okay, now what mucus plugging means is that in the midst of this asthma attack, or this is even something that's happening with the viruses and stuff like that, there's a hyper amount of mucus being made. And if their airways dry out, so they get what's called a mucus plug. So this is a dissected bronchiole where they cut it open so you could see. And you could see where the bronchiole bifurcated, this mucus plug lodged. That means that patient could not breathe through that bronchiole. That's a large bronchiole. That's not a small one. This over here at the bottom is an exaggerated mucus plug that obviously probably came out of some dead person, probably somebody with cystic fibrosis. But this basically, if you look at the size of it up here, that had to be right up in one of the main stem bronchi, and then all these different, roots of it were in all the different bronchioles, on one side of the heart. And here's another one. So why do asthmatics get mucus plugging? Because they're breathing very, very fast. And we contribute to that if we just put them on dry oxygen, right? The oxygen out of a tank that we carry has zero humidity. So if you just put them on it without it running through a humidifier, then you're going to contribute to mucus plugging. So really, anytime we're giving oxygen to a respiratory patient, it should be going through a humidifier. And in general, actually, you should be always giving oxygen through a humidifier. We just don't do it in Rockland County because, we say we have short transport times and stuff like that. But if you remember visiting patients in the hospital, anybody who was on oxygen, it went through a humidifier. Okay, so, but you could get away with it in a short transport. But if you have a respiratory patient, they should be on humidified oxygen. Kids are very susceptible, especially asthmatic kids, to mucus plugging and stuff. So you should have some disposable humidifiers, one-time use humidifiers on your ambulance that you could hook that hooks to the oxygen, and then the oxygen tubing hooks up onto the humidifier. It only works once you're in the ambulance. It doesn't work on a portable tank very well. So it has to be the wall-mounted one. Okay, so any questions on mucus plugging, humidified oxygen, or anything like that? So we said there's a lot of different triggers of asthmatics. It doesn't really matter to us, what their particular trigger is, but, there are a lot of different reasons. Okay, the classic sign of an asthma attack is wheezing. And the wheezing is caused by the terminal bronchioles, which are the small bronchioles right above the alveoli, spasm. So when you breathe in, right, it's under force. You actually open up those bronchioles, air gets down into the alveoli. Okay, the problem is exhalation. Asthma is an expiratory exhalation problem. So when they try to exhale, it's passive, right? The air is just the chest is kind of pushing down a little bit. There's no real muscle work with exhalation. So now the air is getting forced through that narrow bronchiole, and it's making a whistling sound, and that's what the wheezing is. It's like when you put your fingers to your lips and blow air and you make a whistling sound, it's the same thing. So by giving them the albuterol, we're opening up that bronchospasm and getting rid of the wheezing and stuff like that. Now, it is possible to have cough variant asthma. So you see down there, there's tachypnea, which is fast breathing, tachycardia, fast heart rate, cyanosis, which is a rare sign in asthma. I mean, cyanosis is a rare sign in general. You've seen more cyanosis when you look at kids in swimming pools and their lips are blue because they're cold than you've seen cyanosis on a respiratory patient. It's a very rare sign, that you find, in patients. I can remember maybe a dozen times finding people cyanotic that were actually alive, and having breathing problems. Now, cough variant asthma is where instead of wheezing, they cough. It's not a hacking cough. It's like that type of, where they just can't get it out. And that's also what you see when you give them the albuterol and you start making them better, right? So if you had somebody who's wheezing and you start giving them albuterol, they start opening up, they do get that little cough, and that's telling you the albuterol is opening them up. But in cough variant asthma, they have that in lieu of the wheezing, and you could still treat them with albuterol. That's fine. You will get some asthmatics to tell you, please don't give me albuterol, it makes me feel horrible. So it's the only drug we have to treat them, so it's that or suffer. There's not much else we have. The horrible is the jitteriness. It makes them very jittery and nervous and stuff. And also, some parents will not want you to give straight albuterol to their pediatric patients. There are versions of albuterol, okay, that are pharmacologically modified for children. The problem is that we don't carry them and they're astronomically expensive. So if the family has that and that's the only thing they want the patient to use, you can call medical control and ask them if it's okay if you substitute, you know, the family's better albuterol for yours and stuff like that. And I'm sure they wouldn't really have a problem with it.
Frank,
Yes, Laurencia.
I have one thing to say. My son has asthma, and we absolutely took him off albuterol because it gives him horrible, horrible night terrors.
Yep.
Found out. So albuterol is for some kids, it's a big no-no.
Oh, yeah. Yeah. No, you would definitely have parents who will fight you on it. You know, the other thing that's an interesting drug as far as not doing what you think it would do is Benadryl. Like, we never give Benadryl to asthmatics. It'll make them, it'll dry them out 1, 2, 3. But sometimes some kids get Benadryl, they get sleepy. Some kids get Benadryl and they're like, you know, on amphetamines, you can't calm them down and they're jumping and, you know, albuterol will make you jittery. I mean, I once had a bronchitis and I was homesick, you know, and my wife was tired of putting up with me, and, you know, I was moaning and groaning and everything. And she's like, just call the medics, have them come over and give you albuterol treatment. And I'm like, I'm not calling the medics to my house. So I drove to the medic station, stole the albuterol, had an oxygen tank, gave myself a nebulizer. Within 15, 20 minutes, 100% better. Could breathe, everything's wonderful. I could not sleep for like 18 hours. I was cleaning my closet. I was, you know, because I never had albuterol before, and I was all jittery and you know, tachycardic, but I could breathe. So you will get some people who really don't like it, but you just explain to them, it's the only thing we have to treat you. If you don't want it, that's fine. We'll just drive you to the hospital, but you know, that's all we have. Okay, some other things you can get is accessory muscle use, right? So the normal muscle of breathing is your diaphragm. So if you see them starting to use their intercostals and stuff like that, you know, a lot, where you get the in-tugging between the ribs, that would be an accessory muscle. If they can't speak in full sentences, that's another sign, right? If they start getting very scared, you know, telling you, please help me, I feel like I'm going to die. It's either just a nervous Nelly or they're getting, you know, very hypoxic, so they're anxious, and that's sometimes hard to tell the difference. In all asthma, they have that prolonged expiratory phase. It takes them twice as long to exhale as it does to inhale because it's so hard to get it out. They may be in the tripoding position where they're kind of supporting themselves on their arms. They don't know to do that. They just find that to be the most comfortable position. And when they do that, they actually let their diaphragm come down a little further, so they actually get a little more air. Like if you press down on your arms when you're sitting, you're lifting your chest cage up a little bit, so your diaphragm can go down a little further, and you actually get a few more milliliters of air in. And nasal flaring, again, not so common in adults, okay? Maybe COPD, but when you're really sucking a lot of air, you can see some nasal flaring, okay? Now, the most dangerous condition in all respiratory conditions is what's called respiratory failure. So respiratory failure means that they've been huffing and puffing, right, for hours trying to deal with their respiratory condition. And lactic acid started to build up in their respiratory muscles. And when that happens, the muscle fails. Now, they don't stop breathing, but they breathe shallow. And the concept is that they breathe air in what's called the dead air space. So the space from your nose to right above your alveoli is called dead air space. And the reason it's called dead air space is that there's no gas exchange that takes place. So you need to breathe through there, right, to get it down to the alveoli, but the only place there's gas exchange is in the alveoli. So when you start to breathe shallow, okay, you have air, only air moving, not only air, but most of the air is only moving to dead air space. So I'll give you an example. Right now, we're breathing about 500 milliliters of air. Okay, I'm probably breathing a little more because I'm talking, but we're breathing about 500 mLs of air. That's less than a little, you know, water bottle that we typically drink. Okay, so it's not a lot of air. Out of that 500 milliliters of air, okay, 150 of it gets stuck in the dead air space. So from your nose to your bronchioles, 150 gets stuck. So that leaves 350 to have gas exchange. Now, let's say that your muscles start to get weak, and instead of breathing 500 mLs of air, you can only breathe 300 because your muscles are tired and weak. So that means 150 still gets stuck in the dead air space. Now, instead of having 350 for gas exchange, you only have 150. Now, you can picture what starts to happen. Their CO2 level starts to rise, their carbon dioxide level starts to rise, their oxygen level falls, their mental status has to start decreasing, okay? And they're gonna start to get tired, they're gonna start slumping over, right? So anybody having trouble breathing never wants to be supine, but if you see them starting to slump over and stuff, that's a sign that, you know, they're in bad shape. Now, to prevent them going into respiratory failure, right, respiratory muscle fatigue, respiratory failure, you can put them on CPAP if they're still awake, right? Because CPAP will increase their tidal volume. Although the problem with CPAP is sometimes when people are short of breath, they get like claustrophobic feeling from it. So you really have to do a good sales pitch to get them to use it. But CPAP will prevent somebody from going into respiratory failure if you get it on early. But if they're already where they have a diminished mental status, then, and you know, especially if they let you lay them down, you're only choice then is to ventilate them with the bag valve mask. Okay. Now remember, now in this COVID situation, you really have to avoid bag valve masks. You really have to avoid nebulizers. You really have to avoid CPAP. Okay. Now, if you have to use it, okay, what I would do is, we can't get the filters. They just don't have them anymore. We had a short supply of them, like 50 of them, and we went through them in the first couple of days. So what somebody suggested was to take a surgical mask and not to kind of stick it into the port, the exhaust port on these different devices, but to kind of just put it over it like you would put it over the patient's face, so that, hopefully you're trapping some of the exhaust that's probably containing the COVID virus. But that's really the only thing you can do, short of not doing it and just driving fast to the hospital. So if you're close to the hospital, patient's still alive, driving fast to the hospital in this situation, is acceptable. It's not ideal. It's not what we're trained to do. I know a lot of people are having philosophical and moral issues with it and stuff like that. And, I would never fault you for treating the patient, but I'm not going to fault you also for not treating the patient the way you normally would. But getting them to the hospital on a nasal cannula with a surgical mask over it is acceptable in these situations. Okay. So again, to prevent respiratory muscle fatigue, CPAP, BiPAP, okay, would be a good way to go if you get it on early. Okay. If they're already starting to have a decrease in their mental status, then it would be the bag valve mask would be the way to go. Okay, so we know what the lungs are, right? They're solid, they're not bags, they're solid organs, okay, kind of look like a sponge, have miles and miles and miles of bronchioles in there. At the end of every bronchiole, there's a air sac called an alveoli. So this is your, let me bring it back over here. This is your dissected open alveoli, right? Here's your bronchiole. The yellow thing is the bronchiole coming in, and then wrapped around it is the red ones would be your pulmonary capillaries. Okay, well, both of them, the red and blue, but in other words, if it's coming in with oxygenated blood, it's red. If it's leaving with deoxygenated blood, bringing the carbon dioxide out, it's blue, but it's all capillaries. This picture over here is showing the capillary bed wrapped around it, where like it's showing half red and half blue. Capillaries have the same capillary can bring oxygen in and take carbon dioxide out. So it's not like you have half capillaries that are for oxygen and half that are for carbon dioxide. They have the ability to, do both. Okay, so that they're wrapped completely, like you wouldn't even be able to see a bronchiole, the surface of a bronchiole. They're completely wrapped in blood vessels and capillaries. Okay, so now what do we do for our asthmatic patients? So in the COVID environment, we would rather use a metered dose inhaler, which is a puffer with a spacer on it, okay, if the patient has one. But if we have to, we would use nebulized albuterol. But let's go outside of the COVID environment. So in the COVID environment, we can use nebulized albuterol. I should have taken out that 1 in 65 because that's gone now. Okay, so let me actually do it now before I forget. Oh, where'd it go? That's not good. Uh-oh. I screwed up. Let's see. Okay, it's back. Okay, I can't do it while we're doing a presentation. So it doesn't have to be between age and 165. All it says is that it's a patient who you suspect having an asthma attack, okay, and they're wheezing. Now, you'd have to technically call medical control if it's cough variant asthma, okay, but if they're just wheezing, you can do it. You can see the slides again, right? They're back up. Can you guys see the slides? Somebody unmute themselves. Can you see this? Yes, okay. Okay, so again, the agency you belong to, and you have to have training in it, right? So your agency had to apply for approval to use it, and you had to be trained in it. Okay, and the albuterol comes prepackaged, as 2.5 milligrams and 3 mLs. Okay, we're going to adjust the nebulizer to 4 to 6 liters per minute. Less than 4, it doesn't nebulize very well. More than 6, you use it too quick. You can start it in the house if you want to, but you do not need to delay transport, to give them medication or anything like that. Most of the times we just bring them downstairs and start them on it unless there's going to be a delay in the ambulance or anything like that. So now on the new protocol, you're allowed to give up to 3 doses. The old protocol was 2, so you can give up to 3 doses, and you should not fear giving 3 doses. So if you gave the first one and they're not 100% feeling better, go ahead and right away and give them the second one. And, again, if they're not feeling better after the second one, give them the third one. From Pearl River, you're probably, going to be getting 1 in max, unless there was some delay in transport. But, and that, well, I'll show you the the nebulizer in a second. So it's a bronchodilator. It does have side effects. Okay, I put minimal, but they do definitely make you feel jittery and tachycardic and stuff like that. So there's definitely some side effects. Nothing dangerous, nothing fatal or anything like that. Again, it comes prepackaged. Okay. You can actually, I've seen people use it where it's in a dropper bottle. So like you actually have to know how much to draw up into a little medicine dropper, and then you put that in a nebulizer, and then you add saline on top of that. But EMS wise, you know, pretty much everybody has it prepackaged. Okay, up to 3 doses. So we know that the nebulizer, right, comes in pieces. This and this screwed together. The easiest thing to do is screw it together to start with. Pour the medication right down here so it doesn't splash anywhere. Then put your T-piece on. This is your T-piece over here. So the T-piece goes over here, and then the mouthpiece. On the newer ones, the mouthpiece only goes on one side, and some of them have some blue tubing or green tubing to go on the other side to help trap some of the exhalation when you do it. And again, hook it up to 4 to 6 liters, and you can go. After a couple of minutes, you're going to see that it's not misting as much as it used to. So just take it out of the patient's mouth and tap this part of it for a couple of times, and you'll get the fluid that all is stuck up in here to drop back down into the misting chamber, and you'll get a few more minutes out of it. Okay. As far as instructing the patient, it'd be better for them to breathe the albuterol deeply and hold it for a second than it would be to breathe real fast and shallow. So a nice deep breath, hold it for a second, then exhale it. They're not going to be able to do that with every breath, but you know, every 3rd breath, every 5th breath, whatever. And you'll see that it'll work much quicker if you have them breathe it deep, hold it for a second, and then exhale. It gives the medication time to be absorbed by the blood vessels, you know, in the lung and stuff like that. This is how we carry it. It's a lot of different, you know, ways that you know, carry it and stuff like that. This is with the tubing on. Okay. This is a nebulizer mask if the patient for some reason cannot hold it. So you don't need to use the T-piece, but you would just, let me go back over here. You would just take this piece, right? It's all screwed together. You don't need this and you don't need this, right? So you need this and this and the tubing. You put the medication in, you take this piece and you, oops, I'm going the wrong way. And then that piece just pumps right up in here. If you don't have the actual nebulizer masks, and if you could see, they just have these huge holes on the side here. If you don't have the actual nebulizer mask, you could take a non-rebreather, just firmly grab the bag part of the non-rebreather and pull it out of this, and then rip the gaskets that are off the little, there's little holes here, not a big one, but tiny, you know, like tiny little perforations over here. Just take the yellow gaskets off it, and you have the same thing basically. And, you know, we use that in patients that can't hold it well. Sometimes it's good if you have a pediatric patient and you want to just gently hold it in front of their face, but not press it on their face. It helps, you know, give more medication that way. You can have the parents hold it over their, you know, face gently. And then the last thing in an asthmatic is that if you have a dying asthmatic that is no longer capable of using the albuterol, right, or they're too tight and the albuterol is not working, with medical control's permission, you can call and ask to use the EpiPen. Now, this is the EpiPen that you have for your anaphylaxis, right? Or it's your check and inject that you draw up for anaphylaxis, depending on how you do it. But in anaphylaxis is standing order, which means you could do it on your own say-so if you recognize anaphylaxis. In asthma, it's always a medical control option. Now, I just have to tell you, it would be very rare that you're going to have to give Epi to an asthmatic. Okay, I mean, years ago, it was the only drug we had. We didn't have albuterol, so we gave every asthmatic Epi. But it's pretty rare nowadays that you would ever have to give Epi to an asthmatic. I mean, most medics have never done it, okay? But if you have a dying asthmatic, you know, they're already unconscious, they're close to being unconscious, they can't breathe the albuterol in, it's the only thing that you could do. Now, it's the same technique, right? So now that you've been trained in, if you've been trained in check and inject, you can give it in the deltoid muscle of the upper arm. If you haven't been trained and you're still using the auto injectors, it would still be the outer thigh, but it's better to give it in the arm because it works much quicker. Any drug given above the diaphragm works quicker than below the diaphragm because obviously it has to work its way back up from the leg, you know, back up to the heart. But, you know, it would be the same thing. The dosing is the same. So remember, an adult dose is, well, first of all, what is an adult? An adult is anybody who weighs over 66 pounds. 30 kilograms or 66 pounds is an adult. If they weigh under 66 pounds, they're considered a pediatric patient. The adult dose is 0.3 milligrams, okay? So it's really 0.30, like 0.30 milligrams. So it's not a full milligram. It's like a third of a milligram, okay? So it's 0.3 milligrams, we abbreviate it. and the pediatric dose is 0.15. So 0.15 is half of 0.30. So the pediatric dose is half. So those are both test questions. And remember, the 66 pounds is the cutoff between adult and pediatric. Adults get 0.3 or 0.30, and you might see it as 0.3. So 0.3 is the same as 0.30. Just that's the way decimal system is. And the pediatric is 0.15 milligrams. Again, it has to be medical control. Okay, and it can be repeated, but again, it would only be with medical control's permission. Now, in the anaphylaxis, you could actually give up to 2 doses of epi on your say-so, right? It's because that's a life-threatening reaction where minutes count, and epi is the only drug that will help a dying anaphylactic patient. Although they did put albuterol in anaphylaxis, but that's for a different night. We'll explain that. But in this situation, it'd be so rare to have to use it, they made it only a medical control option. Okay. And that's basically everything. I put the dosages over here. Okay. So again, if you're doing check and inject, you have to just remember to draw up the right amount into the syringe. Okay, so we're not going to go into opioids or anything tonight. So why don't you guys unmute yourselves if you have any questions or anything like that that you want to ask. Now would be the time.
Yeah, Frank, I have one question.
Mm-hmm.
On the code in the house, it's
Yep.
what, 20 minutes?
20 minutes.
Okay, and then you pronounce it and you stop, right?
Yep, and they do not have to be in asystole. We just had one 2 days ago. What's today? Monday? Yeah, we had one on Saturday that was what they call refractory VFib, which means they used the defibrillator on that patient multiple times, and the patient was still coming back and forth into VFib. And after 20 minutes, in that case, they called medical control because they didn't have to, but they called medical control just to tell them that they had it. And the doctor's like, do not transport the patient. Now, the only out on that is if you feel it's going to be like a confrontational scene with the family, then you could call medical control, have medical control try to talk to the family. But if they're insisting that you transport that patient to the hospital, and you feel it's going to turn into a situation that's going to be dangerous to you, you can transport the patient to the hospital. If the hospital gives you a hard time, then just call me up and I'll deal with it. But it's tough. I mean, we've had situations where patients have coded en route. So if they come from a nursing home and they code en route and you work them, for 20 minutes. Well, let's put it this way: if they code en route and they have a DNR, then you just bring them back to the nursing home. You don't even work them. And the same thing, obviously, in the house. If they have a DNR, you don't even work them. But if they code en route from a nursing home with a DNR, you don't do anything. You bring them back. The problem we have is that we're taking patients from their homes with DNRs, and you can't bring the patient back to their home, right? I mean, I just can't do that. So, in that situation, we bring them to the hospital. Hospital has a fit, So it's like, I don't know. I mean, I had a doctor screaming at me. I said, I tell you what, I'm going to come to the hospital. Okay, I'm going to open your trunk. I'm going to put the body in the trunk, and then you could figure out what to do with it, because what do you want me to do? I can't bring it to the house. I mean, those poor people, I mean, could you imagine? They just lost their father and grandfather, and we're going to bring it back to the house and say, sorry, dig a hole in the backyard. I mean, like, it's insane. I understand the hospitals are under huge pressure, but so are we. We have EMTs and paramedics that really, this is going to affect them for the rest of their lives, some of the decisions they needed to make. It's horrible.
Mhm.
So, I mean, it's truly, truly, truly horrible. I mean, I never, this is going to be my 34th or 35th year. And I never would have thought, short of an MCI, that we would ever be put in this situation. But, it happened, and it happened very quickly. So anything else, guys?
No, thank you very much, Frank.
Okay. So let me ask you, was this a good way to deliver it? I know Bob's telling me he doesn't have to see my face, so he's happy. So, but,
Yeah.
is this
Definitely like this way.
okay? Because I mean, going forward, we could do this. I mean, once even COVID stops, I think the what's the right word? The genie has been let out of the bottle, and the state's kind of like, they're realizing now that there has to be EMTs, and whatever it takes for EMTs to do it, as long as it's legit. So in other words, the way we're going to make this legit is that I'm going to see all the people that were on tonight. I'm going to email you a link to the test, and you're going to take the test. And again, that's going to be your certificate that you passed and did everything. Now it's taped, so if somebody wasn't able to make it tonight, okay, they can, watch the tape version of it and then take the test. I don't have a problem with that. Now, going forward, please make a Zoom account because there are 1 or 2 people that I just see their phone numbers. So technically, I don't know who you are, so I really shouldn't let you, take the test or anything like that. But, obviously I'm going to, but, in the future, just make an account and this way your name will come up. And always try to go in for either the Zoom app on your phone or your computer, because that's, the best way to kind of see, who's what and stuff like that.
Yeah,
Okay.
Frank, I have a question.
Yep.
Do we have to take the test right away, or can we just review everything?
You can take it anytime you want, because again,
Okay.
when you take it is when you get your certificate, and you have 2 tries.
Okay, I want to review all the
Yep.
slides.
You have 2 tries, and I hit all the test questions. When I kept on
Okay.
saying this is going to be on the test, it is on the test. So,
Yes, thank you.
yeah, just remember that I think the one of the more confusing ones is that a heart attack is a thrombotic event, right? That means that there was a rupture of plaque, and the it's not an embolic event or anything. It's not an aneurysm. It's a thrombotic event and stuff like that. Remember that the 66 pounds is the cutoff between adult and peds. The 0.3 milligrams is the adult dose. The 0.15 milligrams is the pediatric dose. And like I said, you have 2 tries. And if you need a 3rd try, just let me know and I'll send it to you. I'll unlock it and send it to you again and stuff.
Okay, thank you.
Okay. Any other questions?
No, just stay safe and healthy.
Yes, everybody, please remember, just treat every patient encounter, or actually, I guess every encounter you have with a person as being COVID positive. Okay. And, don't walk into any healthcare facility without a mask on, even if you're there just to visit. And just be as careful as possible. And from a serious standpoint, if you're up there in age, okay, and you have, comorbidities, or even if you're not up there in age and you're a smoker or a vapor and you have comorbidities, you may want to not treat patients for the next couple of months, because those groups are getting hit much harder. I mean, anybody could get it, anybody could die, but it definitely, the vast majority of deaths are in the 70s and 80s, and those people do have comorbidities. It is hitting young, healthy people who don't smoke and don't vape, but a very small amount of them. So, but I mean, again, we're all friends. We've been, friends for years and years. So, if if that's the case, I would actually defer, going out there and let, I don't want to say sacrifice the younger people, but nobody's being forced to go out and treat patients and stuff like that. But listen, I mean, there's people who have sent their kids to live with their parents because they're healthcare workers and they don't want to come home, to their kids. Not that there's a lot of kids getting it, but there was a death in New York City of a young patient, but they had pre-existing health conditions. But there's people who've literally told their parents stay in the house, don't leave, and sent their kids to them and are FaceTiming with their kids every night, or every day or constantly or whatever, just to minimize the risk because they're healthcare workers and they're exposed and stuff like that. So I think when they come out with the antibody test, right, which will be, it's there now, but it's right now, they're only doing the antibody test on people who've had it or known to have it and recovered and did well, because they want to get their plasma to see if they can, get the antibodies infused into sick people. But at some point, everybody's going to take the antibody test, and you'll know if you were exposed to it, and if you may never have gotten sick to it, and if you have good levels of antibodies, technically you should have immunity to it. So that'll be something, we'll be hearing the rest of this month and next month, but that's something they'll be coming out with. So what else? Anything else, guys? Okay. So everybody have a good night. And like I said, I will send out the link to the test now, and I will also, as soon as the video gets up onto YouTube, I'll send you the link to that if you need to relook at it or anything like that. Okay.
Okay.
Okay. Everybody.
Okay.
All right, thank
Everybody
you.
have a good night, and just
You too.
whoever didn't attend, if they want to attend, then just tell them, just share the link with them to the video or something like that so they could see it, and then tell them to reach out to me for the link for the written exam. Okay.
Okay, Frank,
Okay,
it's Pam.
thank you.
I'm on. I just used my telephone.
Okay, no problem. Is that with you with the phone number?
Yeah, because I tried, honey. Julia set it up for me and everything, and it's just, I can't do it.
I know there's always one, Pam, but I'm afraid of you, so don't worry about it. It's fine. Okay.
Bye, Frank.
Everybody have a good night.
Bye-bye.
Take care. Bye-bye.
Paul.